The Obalon balloon is a 250 cubic centimeter gas-filled balloon that is actually swallowed. So it's contained in a capsule that's tethered to a catheter, and patients swallow that, and then we fill the balloon with this nitrogen mixed gas after it's been swallowed and it's verified that it's in the stomach. One of the beauties of this device is that we can bring patients back and place more balloons. And the Obalon balloon system really is comprised of 3 balloons that are swallowed over a period of time. So not all balloons are swallowed on the same day. The balloons are still removed endoscopically, but they are swallowed. So you remove one of the procedures and, of course, one of the requirements for anesthesia. The Obalon balloon system goal of the trial was to test this balloon in a randomized sham-controlled trial against a control. And what we found is that there was 2 times as much weight loss with the Obalon balloon compared to the sham control. The other thing that was really surprising, I think, with this trial is that the symptoms were much lower than they were with the balloons that are already on the market. So patients had to have a BMI or body mass index between 30 and 40 to enroll in the trial. They couldn't have diabetes that was controlled with insulin or other injectable medications. So they had to be relatively well controlled. They could have mild high blood pressure. They could have mildly elevated triglycerides or cholesterol. And they had to be between the ages of 22 and 64. The other thing that's really important is that they also had to be able to swallow the capsule. So we did test everyone before they were enrolled in the trial with a test capsule to make sure that they would actually be able to swallow the balloon. The capsules in general, because this is a randomized sham-controlled trial. All patients had to swallow capsules. In the active arm, or treatment arm, those were filled with a balloon. The capsules in the sham control arm were filled with sugar. The other thing that was very important is we did an upper GI series to make sure that patients did not have a hiatal hernia or stricture in their esophagus that could prevent the capsule from being swallowed, or that would pose additional risks for the balloons being inflated in the case of having a large hiatal hernia. So the time frame started out first with day 0, and then most patients went on to swallow their second balloon at week 3. And then patients swallowed the 3rd balloon either at week 9 or at week 12. And that depended on whether or not they were still losing weight. So patients who had completely stopped losing weight got the balloon at week 9. If they had even a small amount of weight loss between their week 6 and week 9 visit, then we waited until week 12 to place the balloon. One of the reasons for that is in previous studies of the currently approved balloons, that most of the weight loss that occurs with those devices, 80% of their weight loss, occurs in the first 3 months. So the strategy for giving an additional balloon at the 9-week or 12-week time point is to help augment that weight loss again, where we know it would traditionally slow down. In the trial, we called all of our patients the day after the procedure and asked them specifically if they were having any symptoms. So we were really eliciting symptom reporting. We had I believe it was 711 incidences of some adverse event. Most of those, 99.7%, were listed as mild or moderate. And that included mild nausea, vomiting, abdominal pain, cramping. These were all, majority of them listed as mild or moderate, meaning either they required no therapy at all, homeopathic therapy with teas and peppermint drops or Altoids, And then in some cases they required additional medication. Now all patients were given abortive therapies, which were an antispasmodic medication and an anti-nausea medication that they started the day before their swallowing and continued for a total of 5 days after the balloon was swallowed. But many patients actually stopped those medications because some of the side effects from those medications were more bothersome than the actual balloon. At my site in particular, we did have one patient that was unable to swallow a second balloon, and so that patient elected to want to have that single balloon removed, since we know that a single balloon doesn't give you much benefit in terms of weight loss, but does give you risk of having a balloon in place. And so we did remove that balloon early. There was also one serious adverse event that occurred, or one serious adverse device event that occurred in this trial, and that occurred with a patient who had gotten a joint replacement and then was put on high-dose non-steroidal anti-inflammatory drugs, which were prohibited in the protocol. That patient developed a bleeding ulcer that needed to be treated, and it's unclear if that ulcer was due to the high-dose NSAIDs or to the balloon, but in any event, the balloons were removed from that patient, and the patient was treated with no sequelae. Well, that is really going to be up to the FDA. The pre-market approval process has been started, and the application has been submitted to the FDA. And from there, the FDA does their due diligence and does audits of sites and of the company. And then from there, they review all of the data and decide whether or not they think that this is a safe and effective product. But we are awaiting the FDA's further action on this. The take-home message from this trial is that with this very rigorous randomized sham-controlled trial design, we showed almost twice as much weight loss in our treatment group compared to our sham group. And we also had twice as many responders to weight loss therapy, meaning that they reached at least 5% total body weight loss in our treatment group compared to our sham group, with really minimal side effects. So I think this is a viable option for weight loss in the future. The next step for this therapy is really to show what it does in a more clinical practice-like setting. So we've shown in an efficacy study that it has twice as much benefit as the sham does. But it doesn't tell us what we can expect to see in clinical practice. Because in clinical practice, we have more contact with our patients, and more importantly, patients know what therapy they have, and that really does play a role into how much weight loss people actually get. So I think really the next most important study that needs to be done with this therapy is in that kind of single arm design where everybody knows that they have a balloon in place, and we give them the kind of therapy that they would get in clinical practice, the kind of lifestyle therapy that they would get in clinical practice. I think that in general, all of us as practitioners, gastroenterologists and physicians in general, really need to recognize that obesity is a disease, and we should be treating it as a disease. We shouldn't be demonizing our patients and blaming the disease and lack of treatment of this disease on the patients. We should be taking it upon ourselves to give them the therapies that will allow them to be successful with their weight loss.